Hello, I'm Dr. Craig Tanner, Medical Director of Housecall Providers Hospice. I came to Housecall Providers because I wanted to be part of an organization that aligns with the values I hold dear. Values such as service, justice, and compassion. My experience at Housecall Providers has exceeded my expectations. In my 25 years of practicing medicine, I've never worked with such a devoted, passionate, and skilled group, and I'm humbled by the opportunity to serve as a member of the hospice leadership team. Housecall Providers has been serving our community for nearly 30 years as a nonprofit healthcare organization that believes everybody should have the right medical care delivered at the right place and at the right time. Our interdisciplinary, team-based services include in-home primary care, palliative care, and hospice services. Thank you for taking the time to listen to the information Heather and Laura are going to share with you in this video. We appreciate partnering with you and your team members to ensure your residents are receiving the best hospice care available. As a community-based organization, we want to be a resource for our partners in care. If you have any questions about our hospice or the information presented, please feel free to reach out to our team for more information. From all of us at Housecall Providers, it is an honor to deliver patient-centered hospice care to your residents.
Hello, my name is Heather Young, and I'm one of the account executives for Housecall Providers Hospice. My role is to help connect our hospice services to patients, community partners, and healthcare providers. I want to make the process of bringing your residents onto service as smooth as possible. We hope this video will help you understand how our team can help your team deliver end-of-life care to your residents. Hospice is a service for people who are at the end of their lives. Our goal is to support patients and families and help your residents live their final moments according to their wishes. We do this by helping manage pain and discomfort in their home instead of requiring them to make visits to a clinic or hospital. Hospice's guiding principles are to neither prolong nor shorten life. We focus on physical, emotional, and spiritual well-being to provide the best quality of life possible. Hospice is patient-centered care that also serves the family. We work very closely with our patients and their families to understand what matters most to them. To qualify for hospice, two things need to happen. First, the patient and the family must decide that they are ready to accept comfort care rather than curative care. As additional healthcare needs arise or if there is an acute event, the hospice team will manage the issue in consultation with the senior living community care team and the patient's primary care provider. This lessens the impact on your residents and keeps them in the environment where they are most comfortable. The second requirement is that two physicians need to certify that if the patient's disease process runs its expected course, life expectancy is about 6 months or less. Hospice is always the patient and family's choice. The form that Medicare requires the patient or family sign is called the election of benefits. Once signed, the hospice organization becomes responsible for all of the healthcare costs related to the 6-month prognosis. Decisions around additional interventions, acute care visits, and appointments becomes a group discussion. Hospice is responsible for 100% of the end-of-life disease-related medical costs. We work with our families and community partners to call us, not 911, when there's any kind of need. Of course, you need to follow the protocols established by your community. Hospice election can be ended at any time by signature on a hospice revocation form. While patients qualify for hospice by having a prognosis of about 6 months or less, there isn't a time limit to hospice. Hospice starts with 2 90-day benefit periods. At the end of each period, a hospice physician will reevaluate disease progression and certify again that the expected prognosis is 6 months or less. After the 2 90-day periods, there is an unlimited number of 60-day periods that, again, require ongoing evaluation to ensure the patient meets hospice eligibility criteria. This process is called recertification. There may be times when our hospice team identifies that a patient's disease progression has slowed. When this occurs, the hospice physician may determine the patient no longer meets criteria for hospice, and the team initiates a discharge plan. We call it graduating from hospice. Discharging from hospice includes much communication with your team and with the patient, their family, and the attending physician. Sometimes a resident may qualify for Housecall Providers in-home primary care, and other times patients may choose to return to their previous primary care physician or PCP. Hospice is covered 100% by most insurance plans. If you have a resident you think will benefit from hospice care, please call our office and we can assist in verifying insurance coverage and eligibility. Hospice care is provided wherever a patient calls home by an interdisciplinary team, including a registered nurse case manager, social worker, certified nursing assistant, and a spiritual counselor. The hospice team is overseen by the hospice medical director who works in coordination with a patient's primary care provider. With input from the patient, family, your team, and the PCP, our hospice team creates a care plan that details the interventions and medications needed to manage symptoms and address what is most important to the patient. The care plan is updated regularly by the hospice team and reviewed by the hospice physician at least every 15 days. There are 4 levels of care for hospice: routine, respite, continuous, and general inpatient care. Routine level of care is when the hospice team can meet all of the patient's needs in their home. Respite is when there is a crisis or a caregiver need and the patient leaves their home environment to stay in a skilled nursing facility for up to 5 days. Continuous care is when a hospice patient has a high need for constant monitoring and the team makes sure an appropriate clinician is at the bedside. General inpatient, or GIP, takes place when a hospice patient has such an acute need that they need to move to an acute care facility temporarily. As soon as a crisis is under control, the patient usually returns to their home. Part of delivering patient-centered care is understanding the desires of each patient. Our team spends a significant amount of time talking with our patients and their families to understand what's important to them. Oftentimes, these discussions result in the creation or refinement of an advance directive and/or a POLST. As your residents' wishes are documented, our team will relay this information to yours. This collaborative effort allows us to work together effectively. Our hospice team is available 24 hours a day, 7 days a week. If there's a crisis or if you need some advice, a change in order, to report a fall or a change in condition, please call our office. The team that usually works in your community may not be available, but our triage nurse can help problem solve many issues and, when appropriate, we will send an on-call team member to support you. Now, I'd like to introduce you to my colleague, Laura, who's going to talk about some of the specifics of providing hospice care to our patients in your community.
Hello, my name is Laura Brooks, and I am also an account executive at Housecall Providers Hospice. When patients come onto our hospice services, they are given what we call medication comfort packs. These packs contain medications that will help patients deal with many of the symptoms that can occur at end of life. Even though everyone's end of life journey is unique, we know and understand what is going to happen. We just don't always know the timeline. Therefore, the Comfort Pack not only gives the family and caregiving team control, but it also provides comfort to them knowing that the medications are there should they be needed. The most basic of hospice comfort packs contain medications that address pain, anxiety, nausea, insomnia, and shortness of breath. Typically, when someone healthy is using these medications, the concern is their respiratory rate. When a patient is on hospice care and at the end of their life, lowering one's respiratory rate can help manage symptoms related to their disease process. Under the guidance of a specialized pain and symptom management team, we are looking for the right balance of symptom relief so that your resident experiences the best end-of-life care possible. Medications that may be found in a hospice comfort pack and the symptoms they might treat include morphine liquid. This is used to treat pain and shortness of breath. Ativan, or sometimes it is referred to as lorazepam, can be used to treat anxiety, nausea, or insomnia. Hyoscamine. We use these tablets that dissolve under the tongue to manage secretions that can arise near end of life. Sometimes this is referred to as the death rattle. Halidol or haloperidol treats agitation and terminal restlessness. It can also be used to treat nausea. Dopalax suppositories. These are rectal suppositories used to treat constipation. And Senna, a plant-based laxative also used to treat constipation. Finally, also included in the comfort pack are Tylenol suppositories that can be used to treat fevers and mild discomfort if a patient is unable to swallow. Together, these medications are the backbone of pain and symptom management when providing hospice care to your residents. The more you and your team can explain to the family about what their loved one is experiencing and why, the more comfort you will be able to provide. If you understand what is happening, then you can say, I know this may look a little scary, but this can be part of the dying process. Hospice has instructed me on how best to manage these symptoms. I have medications on hand, and I know the things we can do non-medicinally to provide comfort. The hospice team is also just a phone call away if we need more support. Now I'd like to tell you about what you can expect your residents to be experiencing 1 to 3 months before death. Your residents are likely to sleep or nap more as their bodies are naturally shutting down and they have less energy to expend than before. Your residents may be eating and drinking less because they don't need as much energy as before. In fact, too much food or fluid can cause more harm than good and result in nausea and vomiting. This point is often one of the hardest things for people to accept because for many, food is about loving and caring for a person. They may withdraw from people and stop doing things they used to enjoy and interact less with others. 1 to 2 weeks before death, people may feel tired and drained all the time. So much so, they don't want to leave their beds. They may experience changes in their sleeping patterns, little appetite and thirst, fewer and smaller bowel movements and less urine, which becomes darker as the kidneys begin to shut down, experience more pain, and needing to be turned or moved more often in bed to alleviate aches and cramps, blood pressure and heart rate changes. Fluctuations in body temperature that may leave their skin cool, warm, moist, or pale. Congested breathing from the buildup of phlegm in the back of their throats. Confusion or seem to be in a daze. Breathing trouble, which can be distressing for family members, but often isn't painful for their loved one. This too, like pain, can be managed, but your residents may have a hard time taking medicine by mouth. They could also be experiencing hallucinations and visions, especially of deceased loved ones, which can be very comforting to them. If seeing and talking to someone who isn't there makes the person who's dying happier, you don't need to try to convince them that they aren't real. This is how we honor and meet the residents' needs at end of life. When death is within days or hours, your residents may no longer desire food or water, have little to no urine output and bowel movements, nonverbal symptoms such as grimacing, groaning, or scowling from discomfort. Their eyes tear or glaze over. Pulse and heartbeat are irregular and hard to detect. the body temperature drops or elevates significantly. Skin on their knees, feet, and hands turn a mottled bluish purple. This is often in the last 24 hours and can be cold to the touch. Breathing is interrupted by gasping and slows until it stops entirely. If they're not already unconscious, your residents may drift in and out, but they probably can still hear and feel. In the last days or hours, your residents may become restless and confused and have hallucinations so upsetting they may cry out, strike out, or try to climb out of bed. Stay with them. Try to keep them calm with soothing music and gentle touch. Make the room as quiet and peaceful as possible with lights dimmed. Constantly assure them that you're there and all is well. Ironically, residents may also become clear-headed in their final hours. They may awake, carry on a conversation, and ask for food or drink. There are non-medicinal interventions that can be used to treat and manage symptoms. Some of these include elevating a resident's head or turn them to their side when they are experiencing breathing changes. Offer verbal reassurance and touch them to let them know you are there. Using a cool cloth on their head can provide comfort when they are experiencing body temperature changes. Have layers of cool, breathable sheets and blankets that can be added or removed. Watch for perspiration or other indicators of temperature discomfort. When your residents are experiencing agitation or restlessness, do not restrain or interfere with the repetitive movements. Look around the room. Could they be overstimulated? Are there too many visitors? Is the music loud? Is there a TV on or light too bright? If so, consider dimming the lights, offer soothing white noise or calming music, speak in a calm, slow voice, open a window to let in fresh air. Ask visitors to take a break for a while so the resident can fully relax. When a resident is confused, lethargic, or unresponsive, speak to them in a normal voice. Sit with them. Hold their hand, stroke their arm, massage their feet and legs. Explain what you are doing clearly. Reassure them of your presence and answer their questions clearly and honestly. Always assume they can hear you. Let them sleep and prepare for their transition. Also let them speak about the reality and meet them where they are. Do not contradict what they are saying. Provide reassurance that they are safe if they seem scared. Continue to check, change, and reposition your residents frequently. Use barrier cream to help maintain skin integrity. Respect what their body is telling you regarding intake. Ice chips or moist toothlets can help with dry mouth. One of the hardest decisions is when to call in the family so that they can say their final goodbyes. Let family members and close friends know as soon as it's obvious that death could be near. The hospice care team can help your team prepare for the changes that are coming, both what will happen to your resident and your own physical and emotional reactions too. Even though you've gathered, don't assume it means you'll be there at the end. Often a person doesn't die until those who sat with them for hours have left, as if they were unable to let go while the ones they loved were present. When your resident does pass away, we ask that you notify hospice right away, noting the time of passing. The hospice team will discuss the plan for next steps with you and the family. We also encourage you to do something symbolic together that will honor the resident and allow those who have cared for them a moment to grieve and say goodbye. We trust that this video has provided you with a deeper insight into the journey of your residents as they approach the end of life, and how our hospice team can serve as your partner, ensuring they receive the utmost care and support during this most sacred time.